let's talk about the actual results of the study. So Tom, maybe you can weigh in on this. What were the primary endpoints, and what did you find in comparing the two modalities?
So really, the primary endpoints of the report, the thing that's of note here, are the false positive rate on bone scans comparing to a PSMA PET. And I'll just add one thing to what Jérémie said, which I think is important to realize here. So there are definitely false positives on PSMA PET, right, in the bones. And, I always like to say, with good teaching, we can get rid of the false positives, right, and convert them into true negatives if we know what we're looking at. And as we're learning more and more about PSMA PET, that's true. But the point I think I want to make here is that the false positives on PSMA PET wouldn't have influenced this study. Right. What I mean by that is if you see uptake on a bone scan, you don't see it on the PSMA PET. That's what we're trying to look for, right? The false positives on the bone scan, negative on the PSMA PET isn't influenced by false positive activity, right? Does that make sense? So we're actually using it, the negative aspect of the PSMA PET, to exclude the presence of cancer in this study. So I actually just want to highlight that because I think some people might misunderstand that and think that the false positive rate on PSMA PET would influence the results of the interpretation of the study, but it actually doesn't have any impact on that. So in terms of the study, I think the take-home point is the initial staging patients. So we had 200-some patients we put in to the study, paired bone scans and PSMA PETs. We had 77 or some of the patients who were at initial staging, and 23, 27 of the patients had osseous disease as read by blinded readers on the bone scans. And of those patients seen on the bone scan, 13 of the 23 were actually false positives on the bone scan. There was no evidence of PSMA video. So over 50% of the patients who had bone metastases were characterized as actually M0 in terms of when you use the PSMA PET, right? And so I think that's the important take-home point here is that. Now, as Jérémie mentioned, as you move up in stage, right? So if you go to biochemical recurrence, and particularly MCRPC, that false positive rate drops dramatically. So in the MCRPC setting, when you see a bone met, they have METs, right, on a bone scan, but that's because the prevalence there goes up so much. Nearly everyone has a bone met when you're in the MCRPC setting, and so you actually do have that. So we actually had no false positives on the bone scan compared to a PSMA PET in the MCRPC setting.
Yeah, and so it was really for early stage disease, or really at initial staging, there were significant differences, right, between PSMA scans and bone scans. Is this what you were expecting, or was this a, I guess, surprising finding?
I'll answer that. So that was the goal of the project, right? So I think the motivation here from this was the Stampede M1RT trial, right? So there's a trial that showed that when you treat someone with ADT and abiraterone, they randomize them to get prostate bed radiation therapy, and they showed, hey, look at this, in patients with low volume disease on a bone scan, prostate bed radiation therapy is beneficial, like pretty big impact on overall survival, which was like surprising overall, right? Like that you'd have such a significant impact in overall survival in someone who have known frank metastasis, right? It's a little odd. And anyway, so that's led to a practice change where patients get prostate bed radiation therapy in the setting of metastatic disease. And, I think it is the results that are actually important at the time they were published, which is, hey, we were withholding beneficial therapy, potentially curative therapy, definitive therapy to patients who had localized disease because of false positive bone scans. So it's actually true when you're using a bone scan, right? So the results were actually really helpful and applicable to help prevent patients from being categorized as, no, you can't get RT to the prostate bed. But that result isn't fully generalizable to the PSMA PET era. Right? So in the PSMA PET era, it's totally different. Like 3 or fewer bone lesions does not mean the same as 3 or fewer bone lesions on a bone scan. So I think right now it's an unknown question, right? We don't have a trial that shows what would happen in a patient population if you had bone mets, low volume bone mets on a PSMA PET, that maybe it is beneficial or maybe not, but we don't know. There's no trial data that supports the use of prostate bed radiation therapy in that population.
Well, then, of course, the next question is, should we do such a trial? And I don't know, maybe that's a question for Jérémie. Is the next step to have a trial where you're basically staging, have initial staging with PSMA and directing therapy based on that?
Yes, as an introduction, I want to point out that we're doing additional analysis on these data sets, specifically looking at the MHSPC patients, so metastatic hormone-sensitive prostate cancer patients, the one that are classified with low and high volume by charted criteria. And with other investigators, we're trying to look at quantitative tumor burden on PSMA PET, what is low, what is high, what is low, what is high on bone scan, and try to make some correlation between the two and cross correlation. What we see is that it goes both ways. You had patients that were high volume on bone scan, they become low volume on PSMA PET scan, and sometimes like this, not even metastasis. But it goes also the other way. You have upstaging when you have low volume. They became high volume on PSMA PET scan. You show much more disease. So it goes both ways. So basically, all the rules we had before, based on that method, if we use PSMA PET, we have to change the rules because these are different classifications. So we almost need to redo the trials. You know, now PSMA PET has been approved, is widely available. It is, I would say, almost unethical to perform a bone scan when you have PSMA PET available like that. So I think the window of opportunity to randomize patients with without the PSMA PET is past. Now we just have to do our best, push in the scientific community, academic investigator, consortium groups, industry, to implement PSMA PET right away into the design of the clinical trials and, you know, gather the data. And we have, it's not a bet, but I think it's almost a duty that we have to use the best imaging technique. Of course, we don't know how to use it at best for now, but we have to implement it into the clinical trial because one day we'll be able to harvest the data and understand better the different disease, new classification we get and correlate it with the outcomes because they were built into the trial. The difficulty is that if we wait to have some level of evidence to say, okay, this is how it works on PSMA PET, it is correlated with that outcomes, now we can use it for clinical trials. It will never happen. It will never happen. So we have to push to implement it. And I have to say that CT and bone scan, they were never tested like that. They were just like, for the RECIST criteria, they were just the only method available. So they were put into the trials. And then they played around with the data and they find out some rules. So we have to do the same now with PSMA PET. So of course, I think it's a bit disruptive because everything is built on CT and bone scan. All the rules are based on that. So it's not that straightforward and easy on how to know how to put PSMA PET. But I think that that's really now the next step.
Yeah, well, that's a very interesting, I guess, in some ways provocative point. I mean, it sounds like, yeah, a lot of the ways in which we were staging patients before would be totally different now, right? With PSMA, or how specifically how we would classify different patients. I don't know, Tom, maybe you can weigh in on this as well. Are all trials going forward, should they all be PSMA scan based, even if not, for instance, investigating specifically PSMA targeted therapy?
I think that, so first of all, I think just the FDA approval of these agents changes things, right? When you tried to have this conversation 5 years ago, you had a budget for all these PSMA PETs and it was wildly expensive. Now you can, you know, Medicare coverage analysis, get a baseline PSMA PET in everyone and, you know, unfavorable intermediate high risk disease. And that should be collected in all trials. And it's going to be moving forward in all trials that are designed from here on out. The other aspect of it that's a little different, though, is not just the baseline imaging, it's what you use for response assessment, which is different. And that's not really covered by insurance, right? So like a repeat PSMA PET every 6 months is a different story. And how we want to think about PSMA PET for response assessment, how you incorporate in the trials gets more complicated. I think you can definitely do it as a baseline to characterize your patients and know how you want to, you know, randomize them or what treatment they should get. But how you define PSMA PET progression, when they should be getting repeat PSMA PETs, is that you use a trigger off a PSA rise, and then your endpoint is not always at a standard time frame, but it's based upon when your PSA is rising or something like that. And then we would use PSMA PET progression definitions. Then also just how do you define PSMA PET progression, right? So RECIST was made up frankly, right? Like we chose 30% and 20%, and that sounded good. And so that was what was used. And that had to do with margins of error and things like that. But with PSMA PET now, people are looking at, there's, I guess two general approaches to think about it. One is volume changes, right? So the recip approach, right, where you're segmenting out the volume and you see if volume goes up or down. Then the other approach is lesion counting approach, right? Is there a new lesion or not, like the PPP style approach? And that's sort of, I think of those are the two ends of the spectrums about how you think about response assessment, but there's certainly no consensus on how one should do that. Although hopefully Prostate Cancer Working Group 4 will start to put some guardrails around that and some direction. But it's hard to do. And the other thing I would add is it does depend on what disease state you're in. Right. If you're looking in a BCR patient population, or even the population of the trial we just talked about, right? Initial staging, low volume bone mets, seeing a new lesion is a big deal, right? If you're M0 or you're localized only and you see a new lesion, that's a big finding. If you're MCRPC post-docetaxel, seeing one new sub-centimeter osseous lesion probably doesn't matter at all, right? So how you define progression might need to be thought of differently depending on the circumstance that you're utilizing. And I don't think we're anywhere near really getting a hold of that.
Excellent. Yeah. We're almost at the end here. So maybe just some final thoughts and maybe the next steps for this study or, similar studies. Maybe Jérémie, we'll start with you.
Yes, with the new imaging technique, with the new tool, you need to relearn the rules. So the stage migration, that's something now that is accepted. Everybody agrees on that. There is a stage migration effect. Now is what do you do with the new stages? So of course, these patients, that you treat locally with irradiation of the prostate, and it works, it improves the overall survival. It's, again, the message we want to point out here, it is because, in fact, they were downstaged, as, shown by the PSMA PET, these patients were probably not metastatic, and they are treated with localized disease properly with radiation therapy. So that's the first finding. But again, it doesn't tell you yet what are the new classification and what are the treatments you should do on the new stage obtained with PSMA PET. You see it better, but now there is no yet mature outcome we can harvest. So that's really the next step, is to come up with new rules based on the classification of the new disease stage.
Yeah, because it really, stage migration really goes both ways. It's really one of the main things I learned from this important paper. And Tom, any final thoughts?
Yeah, I guess the other thing I'd think about is I don't think we should be thinking about how do we recreate charted low volume, high volume. Does that make sense? Right? Like I think charted low volume, high volume had its window of opportunity and it's now gone. Right? Like we don't need to find out how many bone lesions equals high volume with low volume. That question's passed. Now we have a different circumstance. We actually are seeing where the disease is, right? We weren't before. We were seeing a thin veil of where tumors were in the bone. And we knew there were other sites of disease. We didn't know where it was, right? So we were using these bone scans as estimates, stuff like that. Now I know I can point there's a met. And so I think the way we treat this changes, right? So we start to bring in metastasis-directed therapy, things like that. And so, it's not about, in my mind, recreating new criterion that mimics the old, but thinking, hey, we're now seeing things in a different way, which should change the approach. So instead of rerunning the RTM1 trial, right, or M1RT trial, and doing it again and saying, hey, it is 3 or fewer, forget that. Say, hey, the trial should instead be, should we add, SBRT or metastasis-directed therapy to the low volume patients, and does that improve outcome, right? Because we can actually now target those low volume patients in different ways. So I think the idea here in my mind is not so much going back and saying, hey, how do we do what we did before, but say, okay, now that we're seeing things correctly and in a different way, how do we manage the patients more optimally now that we have a more optimal imaging study?